Good evening, one and all. So moving towards the next presentation 8 of basic module cycle to the anaphylactic shock. Today our speaker is Dr. Hafiz. He has completed his PharmD from Manipal College of Manipal University and held a position at Manipal Health Enterprises Private Limited in Bangalore as a clinical pharmacologist. His professional journey includes significant contributions to innovations, digital health projects like HIS, Hospital Information System, EMR, with operations team at Manipal Corporations. Currently, he serves as clinical pharmacist and assistant professor at Adi Chunchagiri Hospital in Karnataka. Additionally, he is an active member of Civil Defense under Fire and Rescue Service of Government of Kerala and play a crucial role in disaster management. Cell of India, All India Boy Scout Association and the Healthcare Foundation Kerala. He is also a rescuer with Kerala Forest Department. So before moving forward, I will share some guidelines with you. Hafiz, next slide, please. So post your questions in the comment box and submit the click button. You can answer, questions will be discussed during question and answer session at the end of the presentation. Next slide. You can submit your feedback button below the comment section. Feedback form will be displayed after live session. Next slide. You can claim your certificates of attendance after 14 days of the event. If you are watching the event on YouTube, please log into our website and register for the event to claim your certificates. Next slide, please. Presentation slides can be downloaded from the website, but login is mandatory for the download. Next slide, please. Okay, Hafiz, you can start with your presentation.
Okay, thank you, Dr. Shubham, for the kind introduction. So the today's topic we are going to discuss is about anaphylactic shock. So let's start with a case. For example, a 48-year-old female patient coming with a complaint of rashes all over the body, or some patient is having severe itching or redness all over the body. Along with she is having some hoarseness of voice, sudden changes in the voice, along with the breathlessness. So how you will manage the scenario? Just think about it. So this is one classical feature of anaphylactic shock. It is a severe allergic reaction where our immune system will overreact against the antigen or foreign body. So if you are not treating this condition early, it can lead to life-threatening condition. Even it can lead to hypotension and death of the patient. That's it is a life-threatening condition. It's an emergency. It's a emergency medical condition both in ICU and ED. So I do not have any financial disclosure. So these are the learning objectives we are going to discuss. First, what is anaphylaxis and what is anaphylactic shock? What are the different causes of anaphylaxis? What is the pathophysiology behind developing anaphylaxis? And what are the major symptoms patient will experience and how we can manage the condition? And there is something called the UK Resuscitation Council. So according to UK Resuscitation Council, what are the recent recommendations and some case discussion? So before moving to the anaphylactic shock, let's discuss in brief about what is shock. So shock, it is defined as the state of cellular and tissue hypoxia. The tissue or cells are not getting enough amount of oxygen and nutrients. It is leading to the death or cellular damage or tissue damage. The main reason for developing the tissue hypoxia, it can be due to reduced oxygen delivery or increased oxygen consumption or inadequate oxygen utilization, any of the three reasons. So the most common cause of shock is because of the vasodilation. Whenever there is a vasodilation, the amount of blood which is going to the tissue will reduce. So there will be a tissue hypoperfusion. Because of that, the organ can damage or there will be a cellular damage. So the shock is again classified into cardiogenic, hypovolemic, and obstructive and distributive shock. So I recommend all of you to go back to the FCPA YouTube channel and see all the like in the FCPA faculty already discussed about the each specifically about the cardiogenic, hypovolemic, and obstructive shock in detail. So you can watch the videos from the FCPA YouTube channel. So we are focusing more into the distributive shock because anaphylactic shock is one of the shock which is belongs to the distributive shock. So, what is distributive shock? It is mainly characterized by the severe peripheral vasodilation. Here, the distributive system is affected. From the heart to the tissue, the blood is going through the blood vessels. The blood is distributed through the blood vessels. Some problem with the distributive system. So, because of the severe vasodilation, the tissues are not getting enough oxygen. So the major type of distributive shock are one is anaphylactic shock and other is septic shock. And there is also called a neurogenic shock. The nervous system also playing one important role for the vasoconstriction. So it is neurogenic shock is more common in patients with spinal cord and traumatic brain injury and adrenal insufficiency. Adrenal gland also playing a role for the vasoconstriction. Whenever there is an adrenal insufficiency, it can cause to endocrine shock. And there is something called the abdominal compartment syndrome. So whenever there is a leakage of vascular leakage in the abdomen will expand. That expansion again can compress the blood vessels, which can also lead to the tissue hypoxemia. So here our topic is anaphylactic shock. So while talking about anaphylaxis shock, as I discussed before, it is a rapid onset serious allergic reaction. Since it is a rapid onset, after exposing with the allergen, within second to minute or within half an hour, the patient is going to get all the severe allergic reaction. That's why it is called a type 1 hypersensitivity reaction. Since the type 1 hypersensitivity reaction is caused by IG antibodies, we can also call it as a IG mediated hypersensitivity reaction. So the IG antibody and a mast cell basophil, these are the agents which is responsible for all the cascades of event which is going to happen in this inflammatory reaction. The other very important point we have to think about is the multi-system involvement. If there is only mucocutaneous system or only dermatological system is involved, it is not anaphylaxis. It is a simple allergy. For example, after having any allergic food by any person, suddenly he is having some rashes or itching all over the body. And he don't have any other symptom. It is a simple allergy. We can either treat with a simple antihistamines or corticosteroid. We can give any ranitidine or levocetirizine something. But along with that, there is an involvement of other respiratory system. There is a increased work of breathing, sudden breathlessness. Along with that, patient is having some hypotension. There is a cardiac compromise. Then there is a multi-system involvement. Then we can call it as a anaphylaxis. So as you can see in the image, here one child, there is a severe dermatological problem. The child is having so much rashes and redness all over the body, urticaria. So along with that dermatological problem, sometimes some people will be having edema like tongue edema will be there, lip edema will be there. There will be gluteal edema. That's called like patient will become with the angioedema. So that is all those are the mucus related reactions. So there is a mucodermatological or mucocutaneous reaction along with and at least one of the following which is mentioned in the ABC is there, then only we can confirm it is an anaphylaxis reaction. Patient is having rashes and itching. Along with that, there is an airway breathing problem. Patient is having dyspnea, wheeze, or bronchospasm, stridor on auscultation. If anything is there, it indicates there is a severe airway respiratory compromise. Suddenly, we are seeing changes in the voice of the patient. So that means there is a problem with the airway compromise. Or patients, sometimes patient can come with a loss of consciousness because of the circulatory problem. From when the blood flow from the heart to the brain is reducing, patient can have altered behavior or loss of consciousness. So if something is there or a patient having hypotension, tachycardia, all these are indicating there is a circulatory compromise. So there is a cardiovascular system is involved. Some people will also have gastrointestinal symptoms immediately after exposing with allergens. They are having severe vomiting and abdominal pain, diarrhea, immediately after taking any allergic food. It is not a gastroenteritis. Today, if you are having some food, next day only, if you are having any episodes of diarrhea, then you can suspect gastroenteritis. But within acute onset, within short period of time, patient is developing severe vomiting. That is a GI anaphylaxis. Here, the gastrointestinal system is involved. So there should be a multi-system involvement. That is the primary thing we have to think about. Then we can discuss about the causes. So there is nothing like a specific agent will cause anaphylaxis. Anything can cause anaphylaxis. Even the drug which is using to, even the drug which we are using to treat the anaphylaxis can also cause anaphylaxis. So as mentioned here, the most common drug, the most common agents which will cause anaphylaxis are, one is, well, coming to food items, peanut, shellfish, milk, soya, egg, all the nut items, or sea fish, shellfish, or milk, soya milk, especially in the pediatrics. These are the common agents which will cause the food allergy. While coming to the medication, penicillin and sulfa drug are most prone for the anaphylactic reaction. And some type of insects called which is belongs to the species of Hymenoptera. Hymenoptera species are the species which is having sting in their body. By using that sting, for example, bee sting, wasp sting, by using that sting, they will inject the toxin into our body. That toxin is causing all the problem. So whenever somebody is having any bee sting or wasp sting, we should try to remove that sting by using any hard object like any ATM card or something like that. Then only we can treat the patient. So some people also will be allergic with the contrast like iohexol, which is used in the radio imaging. Some people are allergic to the rubber latex gloves. Some people are allergic to the NSAID, which is commonly using in the emergency department for treating the pain, and anti-snake venom also. So anti-snake venom, which is an antibody which is taken from the horse body. But again, if you are giving injection into the human body, again it is an it is an antigen to us. It is an outside chemical compound we are taking from the outside. So body will, our immune system will act against that. It will cause a series of inflammatory reactions. So anti-snake venom. So when coming to the non-immunological causes, there is like physical factors like exercise, cold, heat, or sunlight. It can aggravate the anaphylactic reaction. And exercise, whenever the patient somebody is having exercise-induced anaphylaxis, we can advise do workout with your partner or somebody along with the doing alone. And he can stop doing workout at notice of any symptoms of anaphylaxis, and keep EpiPen always ready. So EpiPen means like somebody who is having many history of anaphylaxis. They used to carry on EpiPen. They can easily carry in their pocket. Whenever if they're having symptoms of anaphylaxis, they can easily take and inject in their mid thigh or any intramuscular site. So the EpiPen is just an auto injector. It containing adrenaline. Adrenaline is the drug of choice for anaphylaxis. So as you can see in the picture, this is the EpiPen. Here one end is blue color, other end is orange color. So it containing adrenaline. So anybody who are having anaphylactic reaction, they can inject themselves without depending on anyone. So they can hold the EpiPen in such a way like the blue color towards the sky and the orange towards the thigh. That is the simple way to remember. By holding like that, he can inject to the anterior lateral aspect of the mid thigh. In one injection, around 0.3 ml of the adrenaline, it will release on the mid thigh. But in the pediatric patient, there is some changes in the color code. The top color will be green color. It will inject around 0.15 ml of the epinephrine or adrenaline into the patient's body. So the one problem in Indian scenario, the availability is very less. EpiPen is not that available in India. And the cost factor, one EpiPen will cost around more than 12,000 rupees, Indian rupees. When compared to the simple ampule, 1 ml ampule of that, just 13 rupees. There is a huge difference in the cost factor. So a normal patient population will not be able to afford from the low budget area. So these are the steps which is involved in the administration of the EpiPen. Initially, we can pull off the blue safety cap and position the orange end about 10 centimeter away from the outer mid thigh. We can even if the clothed or unclothed, we can inject, but avoid the place where the pockets or something hard substance are there, and swing and jab the orange tip into the thigh at 90-degree angle and hold there for 10 seconds. After removing the tip and massage that area, the deltoid massage that area for around 10 seconds for better absorption. So these are the four major steps. Even we can teach these steps to the patients. It is as a part of patient counseling while discharging the patient. So while going to the pathophysiology, so as I mentioned, it is an Ig-mediated hypersensitivity reaction. For happening anaphylaxis, there should be an allergic exposure first. As you can see in the images, the yellow color thing is an antigen or allergen. So whenever the antigen or the foreign body or allergen is coming to our body, the dendritic cell presents these antigen in the B cells. From the B cells, there will be a release of Ig antibody. This Ig antibody will bind to the surface of the mast cell or basophil. So that is the first reaction. After that, then subsequent exposure, again the same antigen is going to, we are exposing the same antigen, which will directly go and bind to the antibody which is present on surface of the mast cell, or in between two Ig antibody, it will go and bind. Antigen bridges the gap between two antibody molecule. It will cause the degranulation of the mast cell. Whenever there is a degranulation, it will reach the mast cell, will release various chemical compounds like histamine, tryptase, etc. So the histamine is one of the major chemical mediators which is causing the vasodilation and hypotension and other problems. So histamine itself is a vasodilator. Also, it will release the nitric oxide from the blood vessel. Again, it will cause the vasodilation. And also tryptase. Tryptase, it is like just like adding fuel to the fire. It can aggravate the anaphylactic reaction. So these are the first series of things which is going to happen on exposing with the allergen. After that, followed by these major steps going to take place. One is initial phase, compensatory phase, progressive phase, and refractory phase. So just imagine, whenever there is a release of histamine, it will cause vasodilation. When there is a vasodilation, whenever there is a vasodilation, the fluid, it can also cause the leakage of fluid or blood into the extravascular space through the micropore which is present in the blood vessel. So whenever there is a vasodilation, fluid will shift from the intravascular compartment to the extravascular compartment, because of that there will be a pooling of blood in the extravascular compartment, and the amount of the blood will be very less inside the blood vessels. If there is a less amount of blood inside the blood vessels, the amount of blood which is going back to the heart will also reduce. So there will be a reduction in the venous return. If there is a reduction in the venous return, cardiac output will also reduce. Whenever there is a less cardiac output, tissue won't get enough amount of oxygen and nutrients, but tissue want energy. So for getting energy, what tissue will do? It will undergo anaerobic metabolism. In normal way, tissue will go for gluconeogenesis, where the end product is carbon dioxide and water, and ATP will also produce. But in the absence of oxygen, whenever there is a tissue hypoxia, in the absence of oxygen, tissue will undergo anaerobic metabolism. Whenever there is an anaerobic metabolism, ATP will release, but the end product is lactate. The lactic acid or lactate, it will reduce the pH. It will, so if when the pH will reduce, there will be an acidosis. So it can cause metabolic acidosis. That is the things happening in the initial phase, as you can see here. After initial phase, the next phase is compensatory phase. Whenever there is a metabolic acidosis, it will stimulate the adrenergic system. When there is an activation of sympathetic system, when there is an activation of sympathetic system, heart again will try to contract more. It will try to pump more amount of blood. That is the time patient will be having tachycardia. So initially there will be tachycardia will be there as a symptoms of anaphylactic. So heart will try to pump fast, but when in the progressive stage, when the shock progresses, again the compensatory system again going to fail. So again, there will be a buildup of lactic acid, and that time the amount of lactic acid will be more when compared to the previous time. And finally, there will be severe metabolic acidosis, which will lead to the tissue damage. So these are the things which happened. The same thing. I just briefed whatever they mentioned over here. Okay, so The same thing as I mentioned, because of the inadequate perfusion, there will be a cell hypoxia. This cell hypoxia will cause energy deficit and lactic acid production will be there. Lactic acid will reduce the pH and cause metabolic acidosis. That metabolic acidosis will cause activation of the sympathetic system, which is responsible for the vasoconstriction and tachycardia. Later again, it will fail. The compensatory mechanism will fail, finally leads to the destruction or the dysfunction of the tissue. Okay, so now we can see what are the clinical features. So initially, around 80 to 90% of the cases, the patient will be having skin manifestation like urticaria, rashes, itching, all over the body. So some people will be having angioedema. Angioedema itself, it is an differential diagnosis because angioedema can be happen because of the various reasons. It can be because of it can be idiopathic angioedema and ACE/ARB drugs. These also can cause angioedema like predicant and induced angioedema. But if there is an exposure with the allergen and also patients having hypotension, after exposing with the allergen, patients developing this angioedema, lips edema, tongue edema, then it is an anaphylaxis. And also patient will be having ocular changes like itching over the eye, as you can see in the image. Conjunctival edema is one of the classical feature. Or the respiratory symptoms are airway obstruction, laryngeal edema, stridor, wheeze on auscultation, bronchospasm. Suddenly, if there is a severe bronchospasm, it can completely cut off the airway and it can cause to complication, or sometimes there will be changes in the voice pattern. For example, I know the voice of my friend. Suddenly his voice is changing immediately after taking any food or something. Then I have to suspect there is an anaphylaxis. Well, coming to the cardiovascular system, the most common symptoms we can see is the hypotension and tachycardia, loss of consciousness, LOC. When there is an hypoperfusion to the brain, patient will be having loss of consciousness, or he will admit with the complaint of altered sensorium, and tachycardia, flushing, sweating. All these are the symptoms we can see in cardiovascular system. And GI symptoms are mainly abdominal pain, diarrhea, severe vomiting immediately after exposing with the allergens. These are the clinical features. So again, what is the first line treatment for the anaphylaxis? Intravenous antihistamines or intramuscular epinephrine, oral corticosteroid, or intravenous fluid. So here one thing we have to understand, it is like there is something called allergy scale. One hand, it is a minor allergy. Person is having some only itches and rashes and itching all over the body. So in that scenario, we can give a simple antihistamine like avil hydrocot or simple levocetirizine we can give. Or we can give also hydrocot 200 mg steroid. But if the other end is in anaphylaxis, means along with the rashes and itching, patients having breathlessness or other airway problem, that time we should not give any antihistamine and corticosteroid. We have to give adrenaline. So always for anaphylaxis, the first line of treatment, first drug of choice is anaphylaxis. Anaphylaxis or epinephrine, and the preferred route is intramuscular IM route. We should not give any subcutaneous or IV route. So again, well, coming to the management of anaphylactic shock, the initial drug of choice is adrenaline. So what is the dose of adrenaline? Where we have to inject the adrenaline? Adrenaline is the life-saving drug in both an emergency and ICU. So adrenaline, the main uses of adrenaline, as we are aware, we can give in the cardiac arrest and anaphylaxis. We can also give in the severe asthma. If patient is having severe asthma, initially we will give salbutamol or ipratropium bromide or duolin we will give. After 2 cycles of duolin, patient is not improving, then we can give nebulization adrenaline. It's very effective in severe asthma patient. Or somebody is having hypotension along with the septic shock. Hypotension along with the septic shock, we can give adrenaline as a third choice. Initially, we will give norepinephrine, second choice vasopressin. As a third drug of choice in hypotension, we can give adrenaline in septic shock patient. But while coming to the anaphylaxis, the first line agent is adrenaline. We can give IM, where we have to inject the adrenaline in the anterolateral aspect of the mid thigh. In the mid thigh area, we can directly inject the adrenaline. And how much dose we have to give? That is the next question. Around 0.5 ml we have to give. As you can see, the adrenaline vial, one vial containing 1 ml, 1 ml containing 1 mg. So break the ampule, take 0.5 ml of the adrenaline and inject on the IM mid-thigh. Okay, so after giving the first dose of IM adrenaline, wait for 5 minutes. After 5 minutes, there is no improvement in the symptoms. Still patient is having tachycardia, still patient is having hypotension. Again, repeat the next dose of IM adrenaline. So that is the dosage protocol. And how much dose we have to give? Normally in adult patient, we have to give 0.5 ml, but in the pediatric patient, we have to give 0.3 ml. It's like, as I mentioned here, what is the age differences and the dosing. So children's more than 12 years old, it is 0.5 ml. Children less than 6 to 12 years old, we can give 0.3 ml. Less than 6 year old, we can give 0.15 ml. So this is the dosage protocol for IM adrenaline in the case of anaphylactic shock. So here again one question, a 30-year-old female woman came with a history of severe allergy to shellfish, accidentally ingests the shrimp at a restaurant. Within minutes, she started experiencing difficulty breathing, swelling of the lips and face, and hives all over the body. So as I discussed before, in this patient, there is an exposure with the allergens, and also within immediate as acute onset patient is having breathing difficulty, there is a respiratory compromise, there is an angioedema, there is a multi-system involvement. So what is the diagnosis? It is an anaphylaxis or anaphylactic shock. We have so after so what is the most common step in the managing this patient? Immediately as much as possible we can give adrenaline, IM adrenaline. And the next question, after administering epinephrine, what additional treatment might be necessary? So, after giving adrenaline, this is the first drug of choice. After that, we can go for the other antihistamines or corticosteroid. If the patient saturation is less, we can go for the oxygen therapy. So all these remaining management we'll be discussing in the end of the slides. And the case 2, we can see again a similar question. A 55-year-old woman present to the emergency department with shortness of breath, chest tightness, and dizziness after taking her first dose of new antibiotic, trimethoprim sulfamethoxazole. So it is a sulfa-containing drug which is more prone for the anaphylactic or allergic reaction. Her vital signs, BP is 95/60, heart rate 105 BPM, oxygen saturation is 88%. So laboratory tests show elevated in the serum lactate at 3.5 millimole. So here we can see there is a causative agent. Trimethoprim sulfamethoxazole is the a drug which is causing the anaphylaxis reaction. Patient is having cardiac compromise, patient is having hypotension, a patient is having low saturation. Here also, what is the likely diagnosis? Anaphylaxis. And what is the first treatment? So whenever you are hearing anaphylaxis, first drug of choice is adrenaline. Anaphylaxis, adrenaline. Anaphylactic shock, adrenaline. So what additional treatment should be administered based on her symptoms and lab result? So as you can see here, whenever the patient is having any problem with hypotension, we can give fluid, IV fluid, we can give preferably crystalloid like a normal saline or ringer lactate, we can give for preventing the hypotension, or we can also do the leg end elevation so that large amount of blood will flow to the venous return will increase, it will and increase the BP of the patient. And also we can, for if the saturation is 88, we can go for the supplemental high flow oxygen. So like that we can take care of all the symptoms. And the lactate, if there's a lactate production, it indicates there can be a metabolic acidosis. We can send for the ABG, we can see whether it's an high anion cap metabolic acidosis. Accordingly we can do. So here if the patient is having high amount of lactic acid, we after the fluid correction again we can check the lactate clearance, whether there is some formula called initial lactate by minus final lactate by initial lactate to 100. By using that we can check whether the lactate is clearing or not. If lactate clearance is the rating, indicates the fluid therapy is effective. So while coming to the next question, okay, so adrenaline is the first drug of choice. Whenever we are giving adrenaline, we also need to go for other supportive treatment. So other thing what we can do for managing the patient is removal of the triggering agent. If it is an insect bite, or there is a bee sting or wasp sting, we can remove the sting by using any hard object or by using any ATM card, something like that. If, for example, if they are giving any anti-snake venom, okay, this is one of the area many people will be having confusion. So snake bite cases, the only medicine we can give at that point of time is the anti-snake venom. So whenever there is, we are giving anti-snake venom, for example, a patient is coming with any viper bite or copra bite, or for example, viper bite, patient is coming with a severe bleeding. So there's an hematotoxic venom. So for both the Russell's viper or Sword's viper, the only medicine we can give is the anti-snake venom, which is prepared for the big four snake. But while giving the anti-snake venom, the patient developing severe reaction. That time, don't need to think about anything. Stop the anti-snake venom. Treat the anaphylaxis first, because that is the most medical emergency, high risk, the more risk for death is because of the anaphylaxis. So stop all the infusion, stop the anti-snake venom, treat the anaphylaxis. After, when the patient is going to stabilize, then at a slow rate we can start the anti-snake venom. Okay. So the same time, we can manage the ABCDE, airway, breathing, circulation, disability, and exposure. So airway, we have to check mainly in the A part. We have to check whether the airway is patent or not. If the tongue, there is a tongue fall, we can do the Jothra chant. If the patient is having any wheeze or stridor, or we can check whether is there any changes in the voice pattern of the patient, or while coming to the breathing, we can check whether the patient, what is the patient saturation. If the saturation is less than 94%, or if there is a reduced saturation, we can go for the high flow supplemental oxygen, NRBM, whatever. So if the problem with the circulation, when there is an hypotension, as I discussed before, we can go for the crystalloid. We can go for the crystalloid preferably rather than colloids. So first, we can give either normal saline or ringer lactate, or any solution which doesn't containing dextrose like plasmolate also we can give. Giving ringer lactate is not a contraindication. Even the lactate level will be high, but still we can give ringer lactate. But whenever there is a patient who are having acute liver disease, that time we should not give. That is a contraindication for ringer lactate. Otherwise, in this scenario, we can give both normal saline and ringer lactate, 500 ml to 1 liter for adult patient, and children normally we will give 10 ml per kg of the body weight, and we can titrate according to the response. And if you are not able to get the IV access, we can go for the intraosseous access as well in pediatrics. Then what is the role of steroid and antihistamines? So here, as I mentioned before, H1 and H2 blocker. Initially, if a simple allergy, we can give ranitidine or chlorpheniramine maleate. These are H1 and H2 blocker. But it is not a first drug of choice. It will take some time. Even corticosteroid will take some time for getting the action. You can give a hydrocor 200 mg. Most commonly, we are giving for the drug allergy. But it will take 4 to 5 hours. We need immediate action. So preferably, we can go for the adrenaline injection as first choice. A second line of choice, we can go for the H1 and H2 blocker for preventing the histamine release. So example, diphenhydramine 50 mg IV we can give in pediatric 1 mg per kg. Famotidine 40 mg IV we can give. Corticosteroid methylprednisolone 125 mg IV. Prednisolone 40 mg or 1 to 2 mg per kg of body weight in pediatric patient also we can consider giving. So next important thing is the positioning. Here, always we have to try to keep the patient in a laid down or flat position. We should not allow the patient to stand in upright position. So this is very important thing we have to consider while dealing a patient with anaphylactic shock. Whenever the patient is having any respiratory problem or breathing difficulty, we can just elevate the head end so that patient will be more comfortable to take the breath. But if there is a hypotension, keep the patient in a flat position so that the more amount of blood will flow to the brain. And we can also elevate the leg area. If we are elevating the leg around for 90 degree or 60 degree, more amount of all the big arteries are present in the thigh area. So blood from all this artery will go down. There will be an increase in the venous return. BP will increase. Blood flow to the brain also will increase. Also, in the normal clinical practice, whenever the patient is on the monitor support or continuous BP monitoring, we can see on leg elevation whether the BP is increasing or not. If the BP is increasing within 40 to 50 seconds, then it is like we can again give, that means the fluid is effective. We can give more fluid for this kind of patient. In the case of pregnant woman, we can keep them in a left lateral position or in a recovery position. Otherwise, if they are lying down in a flat position, it will again compress the aorta. The uterus part we have to keep in the left lateral position. So these are the important things we have to consider regarding the positioning of the patient. Again, if there is a bronchospasm is there, you can go for the duoline or aerolized beta agonist, albuterol 2.5 mg diluted in 3 ml NS. We can repeat it as needed. So if there is a bronchospasm, initially we can give salbutamol, we can give ipratropium bromide, but patient is not improving after some time also, then we can give inhalational adrenaline also. In inhalation adrenaline we can give. It is also very effective, but it is not the inhalational route of adrenaline is not a drug of choice in the case of anaphylaxis. Maybe some doctors will be having a concern whether to give IM injection of adrenaline. They can try for inhalation, but it's not recommended by any guideline. So while coming to the other adjunctive vasopressors, okay. Here, what we are doing initially, we are giving for any case of anaphylaxis, we'll start them treatment with the IM adrenaline. After 5 minutes, patient is not improving. Again, we are going for the next dose of IM adrenaline. Again, the patient is after 5 minutes. Again, the patient is not improving. That is called a refractory anaphylaxis. After 2 doses of IM adrenaline, patient symptoms are not improving. This is called a refractory anaphylaxis. In the case of refractory anaphylaxis, we can go for the IV route of adrenaline. The dosage is also different. IV adrenaline we can go. Still the patient IV is failing, or IV still also patient is not able to cope up. That is refractory to the IV adrenaline. Then we can go for the norepinephrine or other symptomatic agent like dopamine, phenylephrine, or vasopressin. And also with the patients receiving a beta blocker. If somebody on beta blocker or patients having anaphylaxis because of beta blocker, then there is no point of giving adrenaline because all the beta receptor are blocked by beta blocker. Then there is no receptor which is ready to bind with the adrenaline. That time we can give glucagon 1 to 5 mg IV or 5 minutes, followed by 5 to 15 microgram per minute IV infusion. And we have to observe the patient at least 4 to 6 hours before discharge. And prior to discharge, we can give education about the what is the causative agents responsible for the allergy, how to use the EpiPen, what is anaphylaxis. All this counseling we can educate the patient. And also, if there is the patient is having refractory anaphylaxis after 2 doses of IM adrenaline, patient is not improving, then we can go. We can keep the patient on observation at least 2 to 24 hours. There is incident something like patient experienced anaphylaxis after 12 hours also second episode patient go. So we can all the cases of refractory anaphylaxis we can keep them at least 12 to 24 hours. Now we can just summarize all whatever we discussed. We can summarize it by using this resuscitation guideline. This is the guideline 2021 guideline by the UK Resuscitation Council. So they mentioned the step-by-step process how we can manage a patient who are having anaphylaxis. So if somebody is having anaphylaxis, we will be initially checking airway, breathing, circulation, disability, and exposure. So in the diagnostic part, mainly we'll be looking for the itchy rashes or any airway problem. Patients having any hypotension, any hoarseness of voice, any breathlessness, any reduced saturation. If anything is there, we will make a clinical diagnosis of the anaphylaxis. It is mainly clinical diagnosis. We don't have time for waiting for the lab result and all. If there is a multi-system involvement, immediately within a second 2 minutes after exposing with allergen, then we have to suspect. This is more about the clinical diagnosis. We have to suspect diagnosis. Immediately we can call for the help, especially in the outside the hospital. Most of this kind of emergencies happening around 90% percentage is happening outside the hospital. Okay, so we can call for any ambulance, preferably rather than calling for any vehicle. We can call for the ambulance so that we can keep the patient in the straight position. Also, after that, we can try for removing the trigger. For example, the patient is in the ICU. So if patient suddenly getting any reaction, we can stop all the infusion immediately. So once the patient is stabilizing, we can start the infusion in a slow rate. So and regarding positioning, we can keep the patient in a lie down position. Should not allow him to stand upright. If pregnant, we can keep them in a left side position. And whatever we are doing, the most importantly, we have to give the IM adrenaline. It is not like one after another. We should try to give everything simultaneously. Whatever, if you're delaying, don't delay in the administration of the IM adrenaline. And where we have to give IM adrenaline? In the anterior lateral aspect of the mid thigh, as it is mentioned in the figure. You can see the exact location where we can give the IM adrenaline. If we are having EpiPen, we can inject EpiPen over that point of area. And same time establish the airway. Sometimes patient will, there will be an airway collapse. For example, if somebody is having gluteal edema, as I told, it can even cut off the oxygen transport. So that time, first initial time only, we can keep all the intubation things ready. If there is a very difficult airway, we can go for the surgical ventilation, like jet ventilation, or tracheostomy, whatever. We can go for the surgical ventilation. And at the same time, if there is a less saturation, we can go for the high flow oxygen and apply monitoring pulse oximetry, check the saturation, check the ECG. Sometimes because of the ischemia or reduced blood supply to the heart, patient will be having myocardial infarction. Maybe he is coming to the emergency department with the severe chest pain. So we can monitor the ECG. We can check the BP. So after giving IM adrenaline, wait for 5 minutes. If there is no improvement, go for the second dose of IM adrenaline. Still, if there is no response, then it is called a refractory anaphylaxis. After giving 2 doses of IM adrenaline, patient is not improving, then it is called a refractory anaphylaxis. So refractory anaphylaxis algorithm we can see in the next slide. Okay. So here the dosing, instead of giving IM adrenaline, we are preferring to give IV adrenaline. So whenever somebody is having refractory anaphylaxis, immediately we have to seek the expert help. We can shift the patient to the critical care or ICU from the emergency department. And we can so that we can start the adrenaline infusion also. So while starting adrenaline infusion, either we can go with the that institutional protocol. Okay. Why we are giving adrenaline? Why not we can go for the noradrenaline IV infusion? Actually, noradrenaline, most of the like cardiogenic shock, hypovolemic shock, many shock scenario will be preferring noradrenaline. But in the case of anaphylactic shock, the patient will be having bronchoconstriction. Noradrenaline mainly will be helpful for the increasing the force of contraction of the heart, improving the vasoconstriction, but it is having less effect on the bronchial smooth muscles. But adrenaline is the best to resolve all the symptoms of anaphylaxis. It is better for the vasodilation, better for the bronchodilation, better for the vasodilation. It will increase the force of contraction, the inotropic agent. So for resolving all the complications of the anaphylactic shock, we can better go with the adrenaline. So what is the dose of infusion adrenaline we have to give? Here, first, is IV adrenaline. Whenever we are giving, should not focus on the bolus. We should not give a bolus, IV bolus of adrenaline. In cardiac arrest, we can give IV bolus, but in anaphylaxis, we have to go for the infusion of IV adrenaline, 1 mg in 100 ml of the 0.9% normal saline. Take the ampoule, break the ampoule, take all the 1 mg or 1 mg equal to 1 ml. Take the 1 ml of the adrenaline and dilute it with the 100 ml of the normal saline. 0.9% normal saline. So that infusion bag we can keep in the infusion pump, and we can start the adrenaline in the rate of 0.5 to 1 ml per kg per hour. That is the flow rate we have to keep. So the main thing we have to consider here, while giving if the patient is having hypotension, we'll be giving all the IV medication through one central line. Okay, so we don't need to keep all the IV medication in one hand. We can, whenever the patient is having hypotension, you can put large bore IV cannula in 2 hands. 18 course large bore IV cannula we can keep in the 2 hands. Okay, one hand we can give all the IV medication like IV fluid we can give, fast IV bolus, normal saline or ringer lactate, whatever we can give. In another hand we can give only adrenaline, and also should not give adrenaline in a hand where we kept the BP cuff, because whenever there is a BP reading, the BP cuff will compress the hand. It will prevent the flow of adrenaline. So don't inject adrenaline in hand where you kept the BP cup. These are the things we should be keep in mind while treating the patient. So again, the IV dose of the adrenaline, we are diluting 1 mg of adrenaline in 100 ml of the normal saline, and we are giving in the rate of 0.5 to 1 ml per kg per hour. For example, the weight of the patient is 60 kg. So, for example, we are starting the infusion in 1 ml per kg per hour. For 60 kg patient, then 60 ml per hour we have to give if you are taking 1 ml per kg. Okay, so we can give for 60 ml per hour. If the patient is improving after some time, then we can titrate it to 50 ml per hour, then to 40 ml per hour. Like that, we can titrate the patient. Or if you are starting in 0.5 ml per kg per hour, that means for 60 kg patient, we can start with 30 ml per hour. Then we can increase according to the response to 40 ml per hour, 50 ml per hour, like that. So accordingly, we can titrate it, depends upon the clinical response of the patients. So these are all about the management by using IV adrenaline infusion protocol. So again, if the patient, finally, in case the patient is going to the respiratory arrest is one of the main complications of the anaphylaxis. So the respiratory arrest, it will also lead to the cardiac arrest. So whenever there is a cardiac arrest is happening, we have to follow the ACLS algorithm, advanced cardiac life support algorithm. Okay, so maybe patient may not be having any response. We have to check the response, check the pulse of the patient, check the breath of the patient. There is no response. There is no chest compression or elevation. There is no pulse. The carotid pulse is absent. So it's response, pulse, everything is absent. Immediately we have to start the CPR. We have to go for the chest compression. Well, we have to compress 30 compression, and after that 30:2 is the ratio. We have to give the chest compression. In between also we can give adrenaline every 3 to 5 minutes. We have to check the ECG in between. What is the ECG? Whether it's asystole, whether it's an VF or VT. If VF, VT will give the shock, or asystole, or whatever the ECG, we have to start giving 3 to 5 adrenaline, IV bolus adrenaline every 3 to 5 minutes. So these are, then will be, if any point of time patient is going to cardiac arrest, immediately we have to follow the ALS algorithm, as I mentioned in the last part of the slide. So these are the overall about the treatment protocol for anaphylactic shock. So these are the key takeaways. Rapid identification of anaphylaxis is crucial for prompt treatment. And the first line treatment, always remember, it is a intramuscular epinephrine or intramuscular adrenaline. And we can give all the antihistamines, corticosteroid as the second or third line of choice. Do not administer any antihistamines or corticosteroid before giving adrenaline. Always give adrenaline first, followed by we can give other supportive treatment. And simultaneously, patients having hypotension, immediately go for put the large bore IV cannula. Try to infuse fast, rapid infusion of crystalloid, preferably normal saline and ringer lactate. Later, after that, if you want, you can go for the colloid like albumin. So if there is a decrease in the saturation, you can go for correcting you can go for the high flow oxygen supplement. And patient education is also very important. Educate the patient on avoiding the triggers and proper use of epinephrine, auto injections, about the EpiPen. For pediatrics, you can teach them about how to use the EpiPen, junior pen, and adhere to the guideline, follow established guideline management. So these are the key takeaway I would like to suggest. So these are the references which I used for making the PPT. Okay, so these are the okay. So antibiotic. These are the upcoming presentation by the FCPI in the basic module in infectious disease. Antibiotics intravenous to oral switch by R.A. S. Kumar on June 7th. And antimicrobial loading dose and maintenance dose concept on June 15 by Saidulu Ganda. Okay, so that's all about my presentation. If Shubham, are you there?
Yes, Hafiz.
Yeah.
Thank you for your excellent presentation.
Thank you, sir.
So we have a couple of questions. So what is the difference between anaphylactic reaction and anaphylactoid reaction? Can you differentiate between these two reactions? How can we identify these reactions?
Okay. So, anaphylactic, there are two types of reaction. One is anaphylactic reaction and anaphylactoid reaction. If there is an involvement of Ig antibody, then we can consider it as an anaphylaxis reaction. But in the case of anaphylactoid reaction, there won't be any involvement of antibodies like Ig. There won't be any mast cell stabilization. So that is the one fundamental difference we can think
Okay.
about.
And regarding the pen you just mentioned, so for obese patient, can we give the same dose of the pen, or shall we give a second dose for the obese patient?
No, for obese patient also, we can use the, according to the UK guideline and all other guideline, they're recommending we can go for the 0.5 ml. Even for the obese patient also, we are giving IM route. So in the IM injection, especially in the anterolateral aspect of the mid thigh, we can give 0.5 ml or half of the ampoule, one ampoule containing 1 ml, half of the ml, 1 ml equal to 1 mg. So half of the ampoule we can inject to the any intramuscular area, but preferably in the mid thigh, we can give, even if it is an obese patient also, or if it is a pediatric patient, then there is a difference. We can go for 0.3 ml. According to the age difference, there is some difference in doses. But if according to the weight or obese or lean weight, body weight, and irrespective of the weight, the dosage will be same. But if it is a children's less than 6 years of age, we can go for the 0.15 ml, very minimum dosage. So that's about the dosage for the.
Okay, Atis, thank you. Thank you so much.
Thank you.